cases, up to 60 or 80% of children have certain disorders, mitochondrial disorders.
Hi, Dr. Bogov.
So now we're passing to our masterclass, metabolic and mitochondrial disorders in case of ASD, and Dr. Bowles will present this interesting topic, genetic testing for autism provides a diagnosis in 2/3 of the cases and the treatment options in the majority of the cases.
Hello, am I on now? Do I use my slides or the slides that you have?
Відкрийте, будь ласка, свою презентацію.
If you could open your slides, you can use your slides.
Okay.
And we will have the simultaneous interpretation.
Do you see my slides now?
Все супер, ми вас бачимо, ми вас чуємо.
Yes, we can see them great. We can hear you loud and clear. We can start.
Okay, thank you very much. Thank you for this opportunity to speak to you. This is my first presentation. I'm going to be talking about how genetic testing can make a big difference in not just in diagnosis, but in treatment and in outcomes in people with any neurodevelopmental disorder, whether that's autism or any of the others. So my presentation is going to be a bit complicated, and in particular, I know there's a language barrier. So if you can look down here, and at the bottom here, after this little heart is going to be a summary of each slide. So you can kind of see in each slide what the main part is. I do many different things, but I'm mostly a physician. And this is one of my patients. This is a real case. I've actually seen her just about 2 weeks ago. When I first saw her, she was 13, but she presented, she was given an autism diagnosis at age 6 years. And because she had a developmental regression at that time, she also has some learning disabilities. Her intelligence was normal, and she was in all classes on her grade level, except for 1 year behind in math. At age 12 years, she had a respiratory virus. There's a common cold that everyone in the family had, and she lost all of her academic skills in that one day, the first day of the illness. She also, her behavior regressed dramatically and became almost catatonic. She became like an infant. And then she also had unusual seizure-like events. And you can read here some of the things. These are what I got from the family. Nobody had really noticed that it was asymmetrical. Muscle weakness was more on the left than on the right, and always headache started before the seizures. That was not noted in the medical record. I asked those questions. But the EEG never showed anything even during these events. As many people with autism have other problems, she had problems with migraine, chronic pain, fatigue, and dizziness when she stand, and she had a diagnosis of common variable immunodeficiency. She was treated with IV immunoglobulin and high-dose steroids. So this is a case of autism with normal intelligence with developmental regression at age 6, and then regression at age 12, and regression in autism is very common. The clinical diagnosis really fits a hemiplegic migraine or an episodic ataxia. These are generally due to a calcium channelopathy or a problem in the ion channels for calcium. These are the genes that most commonly cause hemiplegic migraine, and she has a mutation in all three of them. So that is why she has a very severe case, because most people just have a mutation in one of those with hemiplegic migraine. She has a mutation in all three. Hemiplegic migraine is usually caused by mutations in cation transporters. Cations are positively charged ions like sodium, potassium, calcium, and magnesium. The proteins in the cell membrane which move cations from one side to the other are the cation transporters. Cation transporters are common causes of autism as well, and I'm going to show you some of the data on that. I'm very happy when I get a cation transport disorder because I know I can treat it. The interventions were almost all natural substances. One drug was used, the drug acetazolamide. The mitochondrial cocktail, those are multiple natural compounds meant to help the mitochondria and to detoxify the reactive oxygen species that are made. It's important because the mutation is caused by leaky channels, calcium channels that leak calcium into the cell, and or an ATP pump that can't really pump things back out. And she had mutations in all of that. So you need to give more mitochondrial-based products, more mitochondrial-based natural vitamins and minerals to try to give the cell more energy to pump out the calcium that leaks in. Also, potassium chloride. The potassium goes into the cell and it exchanges to pump it exchanges for calcium. And then the one drug I use is acetazolamide, which is cation targeted. It actually pushes potassium into the cell, but you can't do it until you're on a high dose potassium, or else you'll push it into the kidneys and you'll lose it in the urine. On this treatment, she had a dramatic return of cognitive functioning. When she first presented, her functioning was at the level of an infant, but it did improve and stabilized at the kindergarten level. That's age 5 years in reading and 6 years in math. And the same tests that were done a year later, after the treatment, her reading went up to 8th grade, which is age 13. So her reading score went from a 5-year-old to a 13-year-old on the treatment. And her maths went from a 6-year-old to a 12-year-old on treatment. By the way, this is her grade level. She was in the 8th grade. She was 1 year behind in math on the treatment, which is exactly the way she was before her developmental regression. Her regressed behavior resolved. Her ataxia resolved. That's as a baby would walk or a drunk person. Her POTS and anxiety improved. She has some chronic pain and fatigue, but she is a normal girl in high school now. And as long as she stays on the treatment, she's actually, you would think that she's completely normal. Again, variants in transporter genes are common and they are treatable causes of autism. Not all cases can be dramatically treated to this degree, but I've seen many. The learning objectives I'm going to be talking about in this today. First of all, diagnosis. TRIO, that means including the parents, whole genome sequencing. This is the abbreviation in English. That means everything. We can now sequence over 99% of the DNA. There are still some small areas that are very hard to sequence, like near the telomeres and the centromeres. But 99% of the DNA plus can be sequenced, and that is what I do in my patients on a routine basis. If you do TRIO in both parents and the patient, and you can make an actual diagnosis in about 2 out of 3 cases of people with autism. And this is not just with autism, but other neurodevelopmental disorders as well. Epilepsy, and intellectual disability, not quite as high as this, but still high. Epilepsy, higher than this. Most genetic variants that predispose towards autism are not inherited. They are de novo. They are not in the parents, which is why you need the parents to sequence as well. And the majority of the diagnoses that we make are not on the laboratory report, unfortunately, and I will go over that. Other thing is that treatment is that there are many hundreds of genes known to cause autism, and there are probably over 1,000. Every child with autism is different, so there's thousands of ways in which children can have autism, but there are only a few pathways, and I'm going to go over that. And the pathways dictate the treatment. The pathway is, how does the gene predispose towards the disease of autism or something else? And that knowing the pathway can provide individual treatment options. So 2 out of 3 cases I can treat based upon the information that I get from whole genome sequencing. And then I'm going to spend just a little bit of time on the big picture. Many of the interventions that are used by MAPS doctors, sometimes that's called biomed or integrated medicine or functional medicine. Most doctors do not treat autism. That's the same in the United States and throughout the world, but a lot of us do, and we're successful in it most of the time, not all of the time. And many of the interventions that seem to work can be explained by the genetics. And this will explain in scientific terms why people do what they do and why they work. But also, the information I'm going to show you can explain the explosion in global autism prevalence. Autism rates are going up dramatically all over the world. And it's as much as 1 in 15 boys in some parts of the United States are now diagnosed with autism. There's probably more diagnosis than there was before, but it didn't used to be that way. I've been a pediatrician for 30 years. There are far more affected people now than there were before. This is who I am. I'm mostly a physician. I spend half my time doing that total. I am the director of the neurogenomics program at Neurabilities. It is physically located in the Philadelphia area of the United States, but I do everything by telemedicine. I live in California. Right now, I'm in the state of Oregon. I'll be in New Jersey next week. Everything is done by telemedicine. I can and do see patients in Europe. And then I'll go over that a little bit. I'm also the Chief Medical and Scientific Officer and one of the founders of NeuroNeeds, which is a company that makes products for these disorders. In particular, I make products for autism based upon the genetics. I can read the DNA sequences because I was one of the people that set up DNA sequencing for autism a decade ago. I was the medical director of Cortigen Life Sciences for 5 years, but I've been involved in 3 other companies. At this point, I'm not involved in any sequencing company. I just order from the best in the world. And then I was at a university for 20 years, University of Southern California, USC. I had a laboratory, I had funding, and I still write scientific papers, including one I'm going to show you. This is the machine that makes it possible. This machine costs almost 1 million American dollars. It can sequence all of the DNA in a person in about 6 hours. So sequencing is expensive, but it is extremely helpful. And once you have the sequence on the computer, I use it over and over again. When I have the sequence of my patient's DNA, I often go to the sequence data when I get an email, or definitely when I see the patient on Zoom like this. They have a question, there's new seizures, they want to try a new drug. I go to the DNA sequence, tell them this is how you should treat it, or you need to use a higher dose or a lower dose. The DNA sequence is extremely helpful in everything that you do. So it is an investment on your patients. The ability to look at this, of course, is very new, and it's mostly the interpretation of the computer algorithms, which is the newest thing, to be able to go through 3 billion base pairs on a clinical basis, on a routine basis every day and find what's there. That is actually very new. So what I'm going to be showing you today has been published. This was published. I'm this guy here. You may know Dr. Fry. He's a autism doctor, so is Dr. Mentz. This was published in January of this year. So this is all published, peer-reviewed information in an important journal, a Swiss journal, but it's very new. So I'm going to talk about 50 patients because these are the 50 patients that were sequenced. There are 50 patients that I saw personally, all by telemedicine, and they were 50 patients in a row. So I chose everyone with autism that had whole genome sequencing, which I get in everybody. Trio whole genome sequencing, and it was all done by a single lab, Variantix, because they have the best computer software. In fact, they're the only lab at this point in the world that has the software that allows me to do what I do. Hopefully other labs will be able to do that soon. The other thing I wanted to talk about, and I don't want to spend too much time on the methods because this is really complicated. You can go to the paper. But when I say a primary diagnostic variant, I'm abbreviated PDV in Latin letters. That means a variant that is very highly likely to be the cause of autism in that patient, the main cause, more than 50% of the reason why the patient has autism. There are many other variants we found in autism genes in most of the patients, but this is the most important one. To make a primary diagnostic variant, it had to meet a lot of things. First of all, it had to be verified. It had to be real. On IGV, I looked at it myself. I verified that it's actually real. It's not a computer fantasy. It's not a mistake of the sequencing. It had to be coding. It had to change the amino acid code. So a lot of non-coding variants were missed because of this. We just don't have the technology to look at that. It had to be very rare, and it had to be highly evolutionary conserved, meaning it's a very important part of the protein. It also had to be in a gene that's directly related to autism. So new autism genes did have mutations. Genes in other pathways, yes, I found them, but I did not include them here because I cannot prove with high likelihood. So I'm only looking at ones in pathways that somebody has associated with autism before. And therefore, if it meets all these criteria, it's very highly likely that variant is the main cause of disease. This is the first 25 patients. This is the second 25 patients. I know this slide's very complicated, but it's the color that's important. By the way, I'm now looking at 100 additional patients, and I've already looked at 85. So this is the first 50, the 50 that was published. I've looked at another 85. The data is almost exactly identical. Once I get another 15 done, we'll publish that too. The females are in pink. About 1 in 5 are female. That's the same as what you expect. I divided intellectual disability based upon if it was moderate or worse. Those are people that probably will require living at home or in an institution. Those are the ones in yellow. Or mild or better. Some of them have normal intelligence, like this one here, are in white. Exactly half of them were on the severe end and half of them are on the mild end. The ones that are nonverbal or almost entirely nonverbal are in light green. The ones with seizures are in dark green. The ones with developmental regression have tan here, and the ones with tics have blue, which may be a PANS or a PANDAS. I did not exclude them if they had an autism diagnosis. So you can see that this is a very heterogeneous population, and our population cohort reflects the population that many medical autism practices will see. Okay, this is the DNA data, the molecular data. First 25 patients, second 25 patients. These are the primary diagnostic variants, the genes here and here, that are very highly likely to be the main cause of autism. The ones that are blue here have a first-degree relative with a significant neurodevelopmental disorder. If they have mild ADHD or a little bit Asperger, that didn't count. They had to have a significant one that affects their life. So you see some of them have a high family history, many of them don't. This one here, if there's any primary diagnostic variant, a variant very highly likely to cause autism, it's in color here. So you can see some of them I did not find one. these three right here, these three patients here, sorry, I have a viral. I did not find a primary diagnostic variant in them. However, I did find variants in autism genes that may be the cause of it, but they didn't meet all of the criteria to be a primary diagnostic variant. The ones that are in color other than yellow are inherited variants, X-linked, autosomal recessive, autosomal dominant. 20% were Mendelian, inherited variants, which is what the literature shows. But the yellow are de novo variants. These are mutations that are in the child, but are not in either biological parent. And we have the whole parent's diagnosis, so we have paternity is definitely there. And it's not in the parent, it's not in the mother, it's not in the father. Most of the mutations that appear to cause autism are de novo, they're not inherited. And actually, 1/2 of these patients have a de novo variant that likely causes autism. Now, there were other de novo variants that didn't meet the criteria, and they may be causing autism as well, and I can't prove it. It appears that de novo variants are the main cause of autism. In the next 85 patients I did, so far I have 60% of them are de novo. They have a de novo variant that looks like it caused autism. And then, like I said here, these are the variants in autism genes that are rare and highly conserved, but they don't meet all of the criteria. I'm not going to spend much time on this at all. I just want to show there were 46 de novo variants. 31 of them I said are likely the cause of autism. This is the p-value. The control group were, there are variants, de novo variants will fall in autism genes or in genes not related to autism. If de novo variants are causing autism, you'd expect de novo variants that look like they change the protein, that change protein function. Variants that look like they cause disease should fall mostly in autism genes. But variants that look like they're benign, de novo variants that look like they're benign, should not be more in autism genes than in other genes, all the other genes, all the other 23,000 genes. That's how we did this. This is the odds ratio here. It's almost 30. You almost never get in statistics that high. That means every single de novo variant that I said is a primary diagnostic variant is about 30 times more likely to be related to autism than to be a false positive type 1 error. In other words, that it's not related. So almost all of the 31 here, just by random odds, probably all of them except for one are the cause of autism and one of them's not, based upon the statistical analysis. Again, over 2/3, 68% had a primary diagnostic variant. Most of those were de novo, and 20% had 10 out of 50 or 20% had Mendelian variants that are likely the cause. And so 20% were inherited in the classical way that you learned in school about inheritance pattern. This is another way to look at the same data. This is based upon the fact if the primary diagnostic variant was on the laboratory report, is green here. This is the patient number. If the primary diagnostic variant was not on the laboratory report, it's in orange. And I went through the raw data in the back on the computer. I went through the whole genome. The ones that were on the computer, that were on the report, if the laboratory report said this variant causes the disease, it's positive. There's 5 of them. Or likely positive, it's likely the cause of the disease. Those are red. If you just look at the laboratory report and you only care which ones are positive or likely positive, you will make a diagnosis in 14% of cases. If you also look at the laboratory report and look at the ones that are yellow, these may or may not be the cause of autism, and you look at those very carefully, you can increase the 14% to 20%. And if you look at the laboratory report and you look at all of the variants on the report, even the variants that the laboratory said are probably not disease-related, and you look at those very carefully and you decide, well, maybe it is disease-related. Yes, I think it fits my patient. It's up to 28%. So if you do all of that work, the laboratory report can go from 14 to 28%. I found 68%. So when I did this 68% versus 28. So what's the difference in the 40%? It's this here. These yellows are, there's 1, 2, 3, or 4 cases in the entire world with that gene having caused a disease. So I call those the very rares. And these all are novel. This is the first case ever reported with this gene, a mutation in that gene in a neurodevelopmental disorder. There were other cases that are on the computer. The computer was able to say, yes, sequencing labs found in autism patients variants that may or may not be disease-related, but no one published those. So other people had found mutations in those genes, but they didn't publish them. And laboratories don't look at that data. They only look at known disorders. There's enough in the literature to prove that that is a cause of autism. The laboratory found almost all of the known disorders. The laboratory did a great job. Of 18 known disorders, they found 15. By my going through all of the DNA very carefully, I found another 3. The ones the laboratory missed are ones they didn't miss at all. They didn't miss them because the laboratory doesn't look for new causes of autism that are not in the literature, or there's only 1 or 2 case reports. So this is what I've shown you before. All of the yellows are de novo. And then here, I want to show you this again. The ones that have no diagnosis, no principal diagnosis, they have autism genes. The ones that are de novo, they have inherited autism genes. The ones that are Mendelian, they have inherited autism genes too. Autism, like almost all common conditions, in fact, every single common condition is polygenic. When I say the principal diagnostic variant, I'm talking about the one that is more important than the others. But there are others, and these are, you can think of them as genetic modifiers. And they are important in treatment. I aim treatment for these, the main ones, and that's are here. And I also put treatment on these. Many times the mutation that is de novo is not treatable. But these mutations are, like this one right here. This one's not really treatable. This isn't a protein degradation pathway. But this sodium channel variant is highly treatable. So many of the things that I do are to treat these variants here, and sometimes that can make a huge difference. So what pathways are these in? That's where the treatment falls on the pathways. Here are the 7 pathways that are most common in my data. They may be hard to read, but they're the same here, the 7 pathways. Every time that gene is involved in that pathway, I put yes. So you can see these 7 pathways are very important in autism. These are my 50 patients, but if you look at the literature, these pathways are important in other works as well. So what about these pathways? These 6 pathways here are more important in nerve cells in the brain, in the nerve cells in general. So that explains that. The green are all treatable in my experience, and the dark green are highly treatable. So these cation transport, I already spoke about that, like a calcium transporter. This is mitochondria or energy metabolism or the redox state. That is also highly treatable. Amino acids and neurotransmission. These are all treatable pathways. Many times the ubiquinization, it's a protein degradation pathway. I'd say about half the time I'm successful in treating these, about half the time not. Gene expression, it depends on what genes are turned on and off. If it turns on cation genes, I can treat that. If it turns on genes that say in cell division, which is an untreatable pathway, I can't. So it really depends on what the gene is in the gene expression. So 6 of the 7 main pathways are treatable, and 4 of them are highly treatable. You can see down here. That is why autism can be treatable, and even though there's 1,000 genes and every patient has different combination of genes, there are certain treatments which are very highly likely to treat a patient with autism because they fall into these categories, into these pathways. Okay, I've mentioned about diagnosis. You can make diagnoses in cases. Diagnoses are important because you can stop looking for other things. You can give information regarding recurrence risk in additional siblings, which actually is very high in most cases, in many cases. And you can help treatment, and the treatment is the most important thing. I'm going to be talking about the treatment more in the next hour. And I can tell you that probably every single one of these patients, at least 90% of them, were already on mitochondrial targeted supplements before I got the DNA results. I know that they almost all have mitochondrial problems. So I put them on mitochondrial supplementation while I'm getting the DNA results. I'm not going to wait on it because I know they have that and it's going to make a difference. So when I say the DNA made a difference, it's not that the DNA shows a mitochondrial problem and then I treat it. They're already treated with that. It may show a mitochondrial problem and it says I need to increase the dose. That would count. Or I saw a cation process that I need to treat with a certain medication, or potassium, that would count. Or I found a problem in methylation. I need to add more magnesium or folate. Or I found a problem in inflammation and I needed to add in more anti-inflammatories. These are the things that counted. 74% of the time, I made changes in my management based upon the DNA. 60% of the time, it was a non-prescription supplement. And I know in every country, what's considered a non-prescription over-the-counter supplement that doesn't require a doctor and what is considered a prescription medication that requires a doctor to write for it is different. But most of these are just vitamins and minerals. Almost all of them are vitamins and minerals, and they should be non-prescription in Ukraine as well. And almost half the time, one less than half the time, I added a prescription medication based on the DNA. I'm an integrated provider. I believe in diet and that it's critically important, and I use it very frequently, but I'm also believe in medication. I will do whatever is best for my patient. Okay, a lot of people are afraid that if they do whole genome sequencing, they will find everything, and there will be 100 different things they have to test, and they will go to every specialist because there will be a lot of variants of uncertain significance, and they're going to give a lot of uncertainty to the patient. That is not the case. Only 6 out of the 50 patients did I order any additional laboratory testing after the DNA. And only 9 of the 50, 18% did I refer to any other specialist. Almost always it was immunology. I'm not an immunologist. The immunology treatments are important. If I find a gene that causes autoimmunity, inflammation, or an immunosuppression, I will send them to immunology for the proper workup, which is a lot of these tests, and treatment. And also, there's a few cases I didn't find anything at all in the DNA. They were about 10%. I sent those to immunology as well, because if I don't find anything in the DNA, maybe they will find it, because it may not be an inherited case or a genetic case. Okay, what else will you find outside of the DNA? I'm not going to go through all of this, but I found things that people already knew about or that they should have known about. Somebody who could not hear, I found a mutation in a deafness gene. That was not bad news. They already know the patient couldn't hear. He already had a cochlear implant. I found mosaic Turner syndrome, 1X chromosome in someone that already knew that. I found risk for von Willebrand disease. That's a problem with blood clotting in 2 of them. They required additional blood testing. One of them had von Willebrand disease on gene test on testing, and one of them didn't. So, but 2 of them needed to have additional testing. Cancer risk, yeah, I found cancer risk in 4, but 2 of them already knew about it. One of them was a very minor increased risk. And one of them is a severely increased risk. So bad news. One of them, I found that the whole family is at highly increased risk for cancer. That might save their life because they need to get colonoscopy because colon cancer is very common with a BARD1 mutation. They need, and there was a grandmother that died of colon cancer. They need to all get colonoscopies early and that could save their life. Bad news, they didn't want to hear it, but that may make a huge difference. And one of them, I found a mutation in a collagen gene, did some extra testing and found out that they don't have, it doesn't appear to be a real disease. So two of them heard things they didn't want to hear. And one of them turned out to be nothing. So bad news is pretty rare. It can happen, but it's not like you do this and you're going to see all of this problem. Okay, I showed you this before. The important part here is that there are a small number of treatable pathways. In particular, cation transport and mitochondria are very important, and I'm going to talk a lot about those. The amino acids really fit in with the mitochondria and the neural transmission. I'm going to talk a little bit about the neural transmission later, particularly in the second talk today. And the amino acids are going to be picked up in this one and in that one. So I'm going to kind of go over these four pathways and really look at these two. Cation channels. I'm going to show more of this in the next talk, but this is a really major issue. This is the calcium channel A1A. And there was a mutation in the patient that I showed you. This right here is the pore in the center that the calcium goes through. The problem is that in these mutations, the calcium leaks. The pore doesn't close completely and calcium keeps leaking in. When calcium leaks in, it causes the cell to be positively charged. Positively charged cells are hyperexcitable. Hyperexcitable cells are going to cause a whole lot of trouble. Think about autism for a minute. You have a lot of extra movements. You have hyperexcitability. You have anxiety. You can have ADHD type things. You can have seizures and migraine. A lot of the problems with autism are hyperexcitability. And one of the main reasons you can get hyperexcitability is because of a leaky channel, either a calcium channel or a sodium channel. It can also be potassium that leaks cations into the cell, making the cells hyperexcitable. So how do you treat a cation channel problem? Well, I've already shown you in that one patient, mitochondrial targeted therapies are really important because a hyperexcitable cell needs more energy. And because you need to pump all of that cation back out, and that requires energy. Potassium is what I treated that girl with. Large amounts of potassium will exchange to calcium to get rid of the calcium. It also gets rid of the sodium. Magnesium and calcium are pretty much are like antagonistic to each other. If you give a lot of magnesium, you can also decrease the calcium. So I use a lot of potassium, magnesium, and I make sure there are no calcium supplements. I don't put them on, I don't take away the dairy from the diet like the milk or the cheese, but I do remove any calciums they may have in supplements, except for, it may be in really trace amounts. So I've said I was going to talk about neurotransmitters as well. I'm going to spend most of that time in the next talk. But there are other supplements that can help with that indirectly with transporters. And there also work on neurotransmitters. And then medication. There are acetazolamide and butamide work at on potassium mostly. They work on cations. And then there are many other drugs that work indirectly for neurotransmitters that indirectly affect cations. A lot of these treatments are the treatments that people recommend in autism, at least in biomed or integrated practices in the United States. And there's a few integrated practices in Europe, but there are more and more of them. Mitochondria, that's a huge one. I don't have time to really go over the evidence of this, and I'm going to show more of this in the next talk. But mitochondria is critically important. I don't know how many mitochondrial talks you've had, or is that most people with autism have mitochondrial dysfunction on testing. I always test it in my patients with a mito swab, because I want to know if they do, how much they do, and if they don't, to think about other things. But in my opinion, it's over 80%, probably over 90% have mitochondrial dysfunction. And there are multiple studies that have been done by Drs. Fry and Dr. Rosignol to show that. Energy is made on an assembly line. This is the electron transport chain, and here's the electron transport chain. Here's the Krebs cycle. This is what it really looks like. The colors are made by a computer, but this is actually an electron micrograph of the electron transport chain and the Krebs cycle. They're not separate, but they're crystallized on the membrane. The electrons start on one end, and they go down the assembly line to the other end. And then this is my recommendations in regarding to treatment of autism. And this will make much more sense on the next talk. Genetics is really complicated. And if you went to medical school decades ago, like I did, or even, that it's learning about autism and to learn about the genetics, you may want to go to a paper. I wrote this 4 years ago with a student, Braca, to go over genetics in really basic for physicians, treating physicians like pediatricians, and genetic testing and everything. It's pretty much a primer. It's a basic article on genetics and genetic testing, but it turns everything to autism. It shows you how the genetics is important in autism, how the genetic testing is useful in autism, what testing has been done historically, what testing can be done now. And there's a lot of case reports in there that can give you some idea as to how the genetic testing made a difference in the patients. So if you're interested in learning more about genetics, then this is an article you can get. So I've gone over the learning objectives here, the diagnosis. If you do trio whole genome sequencing, that you can get a diagnosis in 2/3 of the cases. Almost all of them, not all of them, but about 90%, I can find genetic genes that are likely related to autism. That can be very helpful to understand the problem in your patients and to know what, other testing may not be needed. However, the majority of the precise diagnosis were not on the laboratory report, and they require additional expert work. I'm setting this up with your doctors that are involved in this very talk here to be able to do this in Ukraine. I will work with you. I don't have a Ukrainian medical license, so I cannot speak directly to your families, to the patients, but I can speak to the physicians. I can help them to order the right test, make sure the right test is ordered, make sure to read the test and to understand it all. On a Zoom call, we will go over the DNA data so that they understand, because they are responsible for treating, and we can discuss treatment options. We also talk about the patient, because if I don't understand the patient, I really can't understand how the DNA makes a difference. So I get the medical records. I talk to the doctor. We discuss the patient. I have a feel of the patient. Then we go over the DNA, and then we discuss what the options are and what might be done. And we can do a follow-up after that if you want, if it's needed. Treatment. Most of the time, the DNA does lead to treatments. People always ask me, well, how many of them got better? That's very hard to know, because a lot of people are doing other things and patients are changing. The best data that I have is about 50%. About 50% of the patients got substantially better based on a treatment that was not started until the DNA. The DNA said, do this, we did it, and they got better. About 50%. That means the other 50% are, we found nothing, we found something that's not treatable, we found something that's treatable but decided not to treat, or we decided to treat and it didn't really work very well, or it had too many side effects and we had to stop. All of that is 50%. 50%, we found something, we tried it, it worked, and they stayed with it. So those are not bad odds, but it's not guaranteed that we're going to be able to fix anybody. Some patients got dramatically better, like the girl I showed you at first. The next hour, I'm going to go over one that's substantially better, but not dramatically better. Sometimes people, so it varies. The other thing is I made a little teaser about this. Well, we already spoke about how the MAPS or the biomed makes a difference. A lot of the stuff that's being done is direct, but that people do is directed at neurotransmitters or at energy or at cations, even if you may not know what it is. And that explains a lot. And also neuroinflammation was not really big in those 50 patients because it doesn't show up so much in the DNA, but I use a lot of anti-inflammatories in autism as well, and I send them to immunologists sometimes. So those are the pictures, but I also teased about this. Why is autism exploding so much? When I was in medical school a long time ago, I graduated in 1987. I heard from my professors that there's this disease called autism and you may see it once, and how interesting it was and everything. And little did I know that 1 in 15 boys are going to have it 40 years later. It's not all because, some of it is because we know about it and they're getting more diagnosis, but it was not 1 in 15 boys had problems back then. Anyone who's been in the area long enough can tell you that. People don't like to think about it, but autism is a genetic condition. Here's the data, here's the meta-analysis. Most of the meta-analysis that look at large number of studies are saying around 80 to 90%. I like to say 80%. There's definitely an environmental component. In fact, the regression you get seems to be very highly environmental. Those patients that regress and those patients that don't regress, there's a big difference usually in their outcome. I showed you one that regressed that got completely better. That's not always the case. Sometimes they regress and they never get better. Environment is important, but genetics is at least 80% of it. And this is really complicated and I don't have time to go over it, but this line right here is equal concordance in identical monozygotic and in fraternal dizygotic twins. So if it's an environmental condition, you'd expect it to be on this line. Like coronary heart disease is mostly environmental. Interesting, Parkinson's mostly environmental. The further you get from the line, the more genetic it is. Yeah, Rett syndrome and Down syndrome are entirely genetic, 100%. But they're also relatively rare conditions. The two most common conditions that are highly genetic are Tourette syndrome and autism. And autism is the only highly genetic common disease. It's the most genetic of all common diseases. So we've got a problem here. Autism is highly genetic, but it's also treatable in many or if not most cases. I believe strongly that I can treat it in most cases. And I think that at least 80% are substantially better, at least moderately. But then the autism rates are increased dramatically. Most people are saying that's environmental. We're really messing up the environment and autism is going up dramatically. People's genes don't change that much, or do they? And most parents and people with autism are unaffected. But these are all true statements that have been proven over and over again. You can not believe them, but they are true. Multiple laboratories throughout the world have shown that these are true over and over again. We have to figure out how they can all be true. The de novo mutations make sense. They are genetic, but they are not inherited. The de novo mutations are likely. Why do people have mutations? Well, some of it's just background mutation rate, but a lot of it has to do with chemicals, what we're doing to the environment. By the way, almost all of these mutations occur in the sperm, in spermatogenesis. They come from the dad. I usually don't publicize that much, but about 90% are from the dad. And the other 10% are from the mom or they're in the early zygote. They didn't come from either parent. So we are doing something that is causing boys to get mutations that their children with autism, maybe 30 years later, they're children with autism. It's not, these mutations are probably not occurring just before conception. These are in the male germline. And we're doing things now that are going to affect the number of autism cases years, maybe decades later. And here's just some of the things. Also, mitochondria is a major part of autism. And if you have a genetic cause for mitochondrial dysfunction, environmental causes are going to make that all much worse. And all of the environmental causes of mitochondrial dysfunction make it worse. So in the environment, we're causing mutations like cadmium. Don't have time to go over all of it. There's a lot of things in the environment can mutate DNA, but a lot of things in the environment can also affect mitochondrial function, causing secondary mitochondrial dysfunction. It's probably why I'm seeing like 90% of people on the autism spectrum have mitochondrial dysfunction. It's not 90% of people in the population because, I mean, it's mitochondrial dysfunction relative to controls. So there's something going on. And it's environmental affecting the genetics and environmental manipulating the genetics. And then here is my information, and I hope that you can take a screenshot of that or whatever. Neurabilities, the website and the email. Elizabeth, she is my coordinator that can set something up so that I can talk with your physician. Hopefully I'll set things up with the physicians in Ukraine that might be interested in working with me so that I can see patients there indirectly and legally. And then if you're interested in the Neuro Needs products, which I'm mostly going to go over in the next hour, that's my information there. And then this is the easy article on, relatively easy to understand, tried to make it that way as best I could on genetics. So it is 7:50 now. Should we have a 10-minute break or a question and answer period, or do you want me to start on the next one, or what does everyone want me to do? I haven't heard from anyone from a long time, so I really do hope that I'm still on there. Hello? Vladimir. I can't hear you.
Доктор Болс, у нас трошки затримка йде по часу. Ваші повідомлення.
Dr. Bowles, we have a little time lag, but that's why we can hear a bit later. So how many minutes of the break do we need? 10 minutes before we start the second presentation?
That's up to the organizers. It's 10 minutes before the next hour starts. I'm willing to start now or whenever they say.
От перейдемо до другої частини. У нас коротенька пауза, о 18-й годині ми продовжуємо.
Okay, ladies and gentlemen, we have a short break and we continue at the beginning of the next hour.
Короткої паузи ми зараз будемо продовжувати. Власне,
Okay, after a short break, we are going to continue. And Professor actually mentioned that one of the strategies is that diet, nutrition needs to be considered, and also certain supplements, dietary supplements should be considered. So Next, we are going to have another approximately 1 hour presentation about treatment. And please think about your questions, because the best question will win participation, free participation in one of the subsequent master classes. And now we are coming over to our final presentation. So autism and ADHD dietary supplements based on most recent data. You're most welcome, Dr. Bowles. The floor is yours.
Thank you. Okay, again, there is the take-home part here on each slide down at the bottom. So I'm going to start again with another case, because it's the patients, is the people with autism is why we're here, to do the best that we can for them. This is a patient that Kelly presented to my clinic as a teenager. She's now almost 40, so I've been treating her for a long time. She had an autistic disorder. She only spoke to her mother. She would not leave the house. It was difficult for her to go to a doctor's appointment, and she would never otherwise leave, and only spoke to her mother. She was very socially inept. When I first saw her, they came to me because she had a migraine that was there for over a year. It never went away. She also had fatigue, bowel problems, dysautonomia, depression, and anxiety. That was a long time ago. At that time, biochemical testing was the best that we could do, and it showed signs of a mitochondrial disorder. And I put her on, at that time, this was my mitochondrial cocktail: coenzyme Q10, carnitine, arginine, magnesium, vitamins B2, that's riboflavin, vitamin C, and vitamin E. So that's the cocktail of like 25 years ago. And she improved on that. But you can see that at that time, it was not what we call now a complete cocktail, which should be more like 40 ingredients. So when we got the DNA capability, I then found that she had 2 mutations, one from each parent, and this gene here that changes glutamine to glutamate. So in glutamate's 2. And that made sense because her Krebs cycle intermediate, she didn't have the low concentrations here. So I think what was happening is less glutamate was going to alpha ketoglutarate, and there was less in the Krebs cycle. So that gave me the idea that I can treat her with alpha ketoglutarate, which is you can say that's part of a mitochondrial cocktail, but there are hundreds of things you could say are possibly part of a mitochondrial cocktail, and I'd never thought about giving that to her. So I gave her alpha ketoglutarate, and she improved dramatically. This is the email that the mother had sent to me at that time. After that, we doubled it, and we doubled it again. So it's 8 times higher than what you see here. Kelly is a remarkable artist. And this is her self-portrait. I have the original in my office. And then this is another that she made. And she now goes and sells her art, and she takes classes. Of course, her autism is not cured, but it is significantly better. Her social abilities are much better than they were before she got a master's degree. And this is just to show you that the metabolic pathways are really complex. And I mean, if the 2 ways that you can handle this is you can do DNA testing to find exactly what the problem is, or you can use a combination product that has a whole lot of things in it, and hopefully you'll hit it that way. I like to do both, but that's my take home from that. So learning objectives from this talk, we've already spoke about energy metabolism and cations being important in autism, and a lot of the treatment has to do with those. Also to neurotransmitters and some of the other ones, but those are sort of the key pathways. And I'll talk about how those are linked together. There are many supplements that can be used for energy metabolism and cations. And again, so that you get the right ones, I recommend combination products. If you look at the literature, these are in my opinion, these are the ones in the literature that have the highest degree of evidence that they help in autism. That doesn't mean there are not others that are important that we really haven't studied yet. And I'll show you a whole list of ones that haven't been studied yet that may be important. And then there are other pathways. Energy and cations are definitely pathways to think about, but there are other major pathways to think about. And I think that many of these pathways probably are being discussed by some of the other people here, including the speaker beforehand. What I could understand from the slides is that things like methylation and neurotransmission and some other things were discussed. Okay, so that's on the pathways. On the treatment side, again, there are many good treatments. Most of it is dietary supplements. Some of it is prescription medicine, but most of it's dietary supplements. There are combination products. So you can use one product that can cover 40 different ingredients and all of the pathways. And the combination products are highly tolerable. They have no significant side effects, certainly nothing severe, and that they often work and they're convenient. And then also I'm going to talk a little bit about the excitatory to inhibitory neurotransmission ratio. I've already hinted at it at the last one, that autism is an overabundance of excitation to inhibition, and there are supplements that can help rebalance that. And again, who I am, I'm mostly a physician, but I'm also somebody who makes products, reads DNA sequencing and does research. So I'm looking at this from all of these different perspectives. It doesn't always look like this, but this is the California desert, not far from where I live. After a rain, it can be very beautiful with all the different flowers. Okay, so I've shown this slide before, and these are the main pathways, and you can see which ones are treatable. And here I'm going to concentrate a lot on these two, cations and mitochondria, because they're important in terms of the numbers. And you can see these are the two pathways here. Not everyone has an abnormality in these pathways on the genetics, but a lot of them have it acquired. Like the redox pathway, remember over 80%, probably over 90% have acquired mitochondrial dysfunction. So it's not just these are the ones that have genetic mitochondrial dysfunction. So these are important pathways in terms of the number of people that have it, but also in terms of treatment. So this is to show you that cations and mitochondria cause each other's problems. If you look over on the right-hand side, these are actually the genes here to show you which genes are involved in that. But if you have a cation leak, like that first patient I showed you in the last hour, if the calcium is leaking into the cell, the cells are hyperexcitable. Hyperexcitable cells need more energy, but they also, you need to pump all that calcium out, and that requires a lot of ATP. So if you have a cation leak, you're going to have an acquired mitochondrial dysfunction in the nerves. And it's going to be worse during times of stress when nerves are firing more, because you're going to have more hyperexcitability, and you're going to have to pump out more because you're constantly opening up the membrane. You're opening up the channels because the nerve's firing over and over again. But if you have an energy deficiency, you can't pump them out fast enough. The channels open, calcium and sodium rush into the cell. And particularly if you have a stress situation and the cell's firing all the time, if you have an energy deficiency, you can't pump the cations out fast enough, and you get a cation leak. You get a cation problem. So if you start with a cation problem, or if you start with a mitochondrial problem, or with both, it's a vicious cycle. One of them leads to the other. And so that's why you need to treat a cation leak with a mitochondrial cocktail. And you have to address too much calcium in the cell when you have energy deficiency. Okay, I went over this one briefly in the other one, but I want to show you, this is at the neuroneeds.com. And if you go to the autism landing page, you will find this part here of the slide. And if you click on each one of those on the website, you will find the evidence that I was able to find that showed that. Like if you click here on selenium, it will show you all of the scientific papers that showed you why selenium is important in autism. If it's deficient in people with autism, and if giving selenium helped with people with autism. Here we'll show you for coenzyme Q10, here for vitamin C, for vitamin D. There's way too much evidence for me to go over it on this talk. I'm only going to go over a tiny, tiny bit. These have not been tested in autism. No one's ever tested them, but they are critically important for mitochondrial function. And therefore, I think that these are probably important in autism. It's just no one's ever looked at it before. Okay, I can't go through all 40 or so that I think are important, but what I can do is I'll just very briefly go over some of the more important ones. I think the big 8, the most important 8. Carnitine. Carnitine works, you need carnitine to get long-chain fatty acids into mitochondria. But it also, if the mitochondria is not burning very well, you get half-burned fats, and you need to get rid of those. You need to detoxify the mitochondria. Carnitine needs to take those out. And so in a mitochondrial problem, you run out of carnitine because the carnitine's taking out incompletely oxidized intermediates, and then you're losing it in the stool and in the urine. And you can't make carnitine fast enough, so you need more in the diet. The other thing I want to talk about, I mean, for metabolic disorders, carnitine is critical. Carnitine comes into 2 forms, L-carnitine and acetylcarnitine, or L-CAR. I went for all the evidence when I made my own products, and I couldn't figure out which one was better. And I decided to do 50% one and 50% the other. They both seem to be important. L-CAR goes to, because of the acetyl group, goes into brain better. So a lot of people say use that. But that already has an acetyl group on it. It's not as, you have to take it off. It's not ready to accept things. The L-carnitine, it's all ready to grab things. So anyway, I will often use both. But whatever form you use, I think that carnitine is very important. Magnesium. Magnesium is used in at least 300 different enzymes. Many of them are in energy metabolism. A lot of them have to do with neurotransmission as well. GABA receptors. GABA is the #1 inhibitory neurotransmitter in the brain. Glutamate receptors. Glutamate is the #1 excitatory neurotransmitter in the brain. Magnesium is important for both of those. Magnesium is important for just about everything. The caveat I want to show you is that people with these problems, I make sure in particular they get a lot of magnesium. If they have problems, like I said, the inhibitory to excitatory balance, they have too much hyperexcitability, anxiety, hyperactivity, impulsivity, obsessive compulsive disorder, any of those, also migraine, epilepsy, etc. Migraine here, restless leg, that's another problem here of hyperexcitability. And then constipation, any of these problems, I will make sure that their magnesium is particularly high, and I will use more magnesium on top of combination products. Coenzyme Q10 is a great antioxidant to remove the half-burned, half-oxidized chemicals that are made, the intermediates to metabolism, but it's also the actual chemical that moves electrons from one place to another in the electron transport chain. And in some other places, there's some other pathways that use CoQ as well. They move them into the electron transport chain from other enzymes. It's a very critical. The problem with coenzyme Q10 is it's very, very lipid soluble. It's not really stable in a powder form. And so you need to take oil forms of CoQ. So most of the mitochondrial cocktails are in powder form. You put the powder in a liquid, or they're in capsules in powder. So coenzyme Q10, you have to think about this because the combination products you really have to use don't have enough, if any, and you have to add additional. And coenzyme Q10 is one of those things that I like to get laboratory testing. It's not absolutely required. If you start with enough of it, of a good brand of ubiquinol type of CoQ, 200 twice a day is probably enough, but it's got to be ubiquinol. Ubiquinol has an OL at the end, not the ONE. In English, none. You don't want the none here at the end. So CoQ comes in an oxidized form, ubiquinone, and a reduced form, ubiquinol. This is 5 times more bioavailable. Yes, it's about twice the price. So a lot of people buy this, and most stores, at least in the United States, have this. But you need 5 times less of this. So it's really cheaper in the dose that you need to get a certain blood level. I only use ubiquinol, and not all ubiquinols are the same. And you have to think about if it's a liquid versus a gel capsule. There's only one liquid ubiquinol in the entire world that I'm aware of that's any good. It's made by the company Epic for Health. It's another company that I'm not involved with. It has a good product. Most people take gel capsules with ubiquinol in it, cut it open, and then flavor it. It's a lot cheaper that way, but then you have to cut it open. And then the oil base. Most of the preparations are in soy oil. Not everyone can take soy or wants soy oil. Limonene, some of the better products are in the lemon peel oil, which is limonene. And of course, price varies. So not all CoQs are the same. And if you get a bad one, the blood levels will not go up at all. I get blood levels on all my patients, and most of the ones out there are useless. Omega-3 fatty acids is very important for general health. It's important for neuronal membranes and myelin inflammation. It's great. It's a great anti-inflammatory. It's for the heart, the whole body. People take it often cosmetic-wise for hair, skin, and nails. The problem is that omega-3s are necessary for life, but you get it in fungi and moss and mold. And in our modern farming practices, we don't get very much. Our ancestors used to eat things out of the dirt and didn't wash them very well and got a lot of omega-3s. The other way that you can get it is from it's in plankton in the ocean. So if a fish will eat the plankton, the omega-3s can be in there, but not if it's farmed, because then it's getting corn or whatever. It has very little. So, and then you can get a lot of mercury if you're eating a huge amount of seafood, obviously, as well. So everyone should be on an omega-3s. And what I mean, these are the major omega-3s. There are many others, but EPA and DHA are the major ones. But omega-3s, the problem is that fish oil is less expensive and almost everyone's on fish oil. Fish oil is great for most people, but it doesn't go across the blood-brain barrier because it is triglyceride bound. It needs to be phospholipid bound to go across the blood-brain barrier. And this is the transporter. And you can actually read the literature that shows that that's how you get the DHA into the brain. The way you get it there is through this system, and it needs to be phospholipid bound. So krill oil is naturally phospholipid bound. So many people in ADHD and in autism will use krill oil, and that's fine. But krill oil is very expensive. And if you want to get high doses of krill oil for the heart, it's extremely expensive. So I recommend taking fish oil and krill oil together because they both have advantages and disadvantages. And then there are some products that mix fish and krill together. And the other thing is that the krill oil has phosphatidylcholine in it, but it doesn't have phosphatidylserine in it. If you want phosphatidylserine in it, you need to take something like, there are some organisms like sunflower seed that have that in it. And so, okay, let's see. Okay, vitamin B6 or pyridoxine. The active part is pyridoxine 5-phosphate. It's involved in over 100 enzymatic reactions. Most vitamin tablets have pyridoxine, not the activated form P5P or PLP. This is the activated form. This is the one that's better for B6. B6 has been, all of the ones I'm showing you here, carnitine, CoQ, magnesium, they've all been studied in autism. They've all have good evidence that they help in autism. P5P has good evidence in autism as well. Folate. I'm sure that other people are going to be talking about folate as well. That's vitamin B9. I just want to say two things about folate. Number one is that there's activated forms of folate that are less likely to have side effects and more likely to be helpful for the brain of your child, regardless of their methylation status and their MTHFR. I don't generally check MTHFR because it's so common. I'm one of those geneticists that don't think that it's worthwhile doing, but I do make sure that all of my patients are on activated folate, so it's not going to cause a problem. Also, folinate, which is known in the United States as leucovorin as well, but folinate goes directly across the blood-brain barrier. And it's a form of folate which doesn't require the folate transporter, because the folate transporter can have antibodies against it, and you can have a brain folate deficiency, and that can cause an autism-like problem. Vitamin B12 or cobalamin, again, another one that's been shown. The activated form is methylcobalamin. Most of the cobalamin that's used in vitamins you'll buy over the counter is cyanocobalamin. There are considerations about using that. It's just not as good. Some people will do injections of B12 as well. I have a lot of autism doctors feel that those injections are very helpful. My patients are all on very high doses of activated methylcobalamin. And when they've taken the B12 injections, they have not really seen improvement, maybe because I'm giving them enough in their diet or in their supplements. Vitamin D is used for the bones and many other things, but you may not know that it's really important for brain. And it's also one of the ones that have been shown to be helpful in autism. Vitamin D is deficient in almost everybody in the world. And it's one of the ones like coenzyme Q10 that blood levels are helpful. I know some people that want the levels higher than 50. Lower than 20 is considered to be very low. Between 20 and 30 is borderline. Many of the autism doctors want higher than 30 or higher than 40. But like I've seen some that have higher than 50. Personally, I like the level to be higher than 40. Between 30 and 40 is sort of borderline for me. But there's different opinions on that. Okay, anybody who has a child with autism or takes care of children with autism will know that their diets are not always perfect. They often will eat only the same thing over and over again, and those are not necessarily things that have good vitamins in it, and certainly not activated vitamins. All of these have been shown in studies to be deficient in children with autism. The green ones are ones that we've already spoken about as being main ones. So you can see that, B6, B9, B12, D3, and magnesium, that's 5 of the 8 I've spoken about, have been shown to be deficient. The reason I supplement them is not because they're deficient in the diet, but that will help, obviously. The reason I use supplementation is to give really, really high doses to push the metabolic pathways in the direction that I want them to. So we are treating deficiencies, but if a child with autism eats really well, it doesn't mean they don't need the supplements. The supplements are still needed. Some people will ask, well, how do I know if my patient has mitochondrial dysfunction? My answer is all of them pretty much have it. But this is a slide when I teach medical school that I show them. You'll see that autism's on the top because autism is one of the it's one of the major things that mitochondrial dysfunction or mitochondrial disease will show up as. But you can see that there's lots of different ones. And I could show you 5 slides like this and it would only be partial. Most of it is neurological because the nerves are electrical and require huge amounts of energy. So this is just some of the things that will cause, you can see regression is a major mitochondrial thing, movement problems. So there's a lot of things, but you can just have autism and have a mitochondrial disorder too. Almost all of this talk is on autism, but ADHD and autism overlap greatly. You can see from the Venn diagram on the left. They are not the same. Autism is a problem in social communication. ADHD is a problem in frontal lobe executive function. But most of the mutations that affect nerve cell function will not only affect one of them, but the other as well. In my experience, at least 80% of people with autism have ADHD. And it's important to know that because you can treat that. It's different treatments and different ways of thinking about it in the classroom. And it makes sense that there's an overlap because, like I said, if it's going to affect the nerve cells and the social communication pathways, it probably is also going to affect the nerve cells in the executive pathways, which are different parts of the cortex, but not that far away. And then we talked about it's an assembly line. I showed this last one. This, by the way, is the Ford Motor Company at the turn of the century, and then Hyundai at the turn of the next century. If you give this guy here his vitamins and he makes cars twice as fast, you're going to have chaos. You're not going to make more cars. If you give them all their vitamins and all of them go twice as fast, then you will make more cars. It's giving 10,000 times the recommended daily allowance of one chemical in autism to see if that works or not is going to cause trouble. First of all, it's unlikely it's going to help, and it likely will have side effects. I really strongly suggest against that. What I recommend is moderate doses of everything that helps the mitochondria, combination products. Moderate doses that are unlikely to cause side effects in anybody and are extraordinarily unlikely to really hurt anybody. And you can always add on top of those. And I use combination products, and almost everyone I give something more. I'll give more magnesium, or I'll add N-acetylcysteine that's not in the product. Great antioxidant, but 1 out of 3 of my patients that I give that to have stomach problems. So I want everyone to be able to handle the product. So moderate doses of everything. You give some vitamins to everyone, then you make cars, and then you decide where your problems are, and you can work on top of that. You have more efficacy. Obviously, if you use combination products, it's going to be better because you're going to hit things you didn't think about, like maybe alpha-ketoglutarate and Kelly, but you're also going to just have more effects because you're hitting more problems. But also you have less side effects. Now, but is that tolerable? This is Bonnie Kaplan in Canada, and she made a product that has approximately 30 different vitamins and minerals, and she aimed it at depression and anxiety in the adult population. It's remarkably similar to a product aimed at autism. I'll show you next, because it's problems in the brain. You're treating issues in the brain that are acquired and congenital, genetic and environment at the same time. And you're helping the nerve cells function, which is another reason why things like anxiety is almost completely universal in autism, that it's not because anxiety is part of autism. It's just that if it affects the nerves that are involved in social communication, it's likely also to affect the nerves that are involved in emotional regulation. Now, this is a double-blind study that was done by Dr. Adams, and this was done, in 2011, so a while ago. And this is another vitamin and mineral supplement that's remarkably similar to the previous one. He showed that it was highly tolerable as well. In a double-blind study, there was basically no side effects of any kind in the placebo group or in the group getting them. But those that were in the group that got the treatment, there were significant differences in hyperactivity, tantruming, receptive language, and overall. And then, of course, their blood levels got better of oxidative stress, ATP levels, all sorts of things. So when I say that this helps in my patients, I'm anecdotal as a physician that most of the families want to continue to buy the products over and over again. But it's also been studied in a double blind. And so this comes down to, again, my recommendations is a high-powered mitochondrial cocktail, multivitamin and mineral supplement. There are different brands of that, and I've shown you 2 before that. the Kaplan and the Adams formula. Their recommended dose is based on the patient's weight, and usually on the label will say, and like in some of them are only in pounds, some are in kilos. The one I do is in pounds and in kilos, so you don't have to worry about converting. I generally check carnitine levels and vitamin D levels, but a lot of people don't. The carnitine levels are almost always good. The vitamin D level, well, that varies so much in people, you really need to check that. Ubiquinol form of CoQ. You really can't put that into the mitochondrial cocktail because the oils and the powders don't mix. I tried, it didn't work. The blood levels didn't go high enough. So I gave up and I private labeled the best one in the world, which was a CoQ QH by Konica in limonene oil. And I like the blood levels to be very high, between 4 and 7. Normal is between about 0.5 and 1.5. So I find that when the blood levels are higher than 4, that you get good efficacy. Higher than 3 is where I find it, but I like it higher than 4, so I have a little cushion there. Omega-3s. We've already gone over that. It's also in an oil, so it won't mix with the powders. I prefer a supplement that mixes krill and fish together and sunflower seed for phosphatidylserine. Some patients need more zinc, particularly if there's a problem in the immune system. I might add more zinc. Many times I'll add more magnesium. GABA enhancing, if they have problems like hyperactivity, anxiety, insomnia, they can't sleep because they're thinking about their day, I'll use things that work on the GABA pathway, and I'll go over that a little bit later. And then this is, I stress that diet and supplements are both necessary, and they're synergistic. You can go eat everything in the grocery store, every single plant, and you won't get as high levels of B12 than are in these combination products. That you need the supplementation to get the high level, no matter what your diet is. But there are a lot of things in the vegetables that are not in the products. They are both necessary. You need good diet and supplementation. You can't have a good diet and avoid supplements. You can't take supplements and have a horrible diet. They're both necessary. And then, of course, all recommendations for this talk and the last talk are meant to be with a physician's advice. I'm here to try to help the physicians to better understand and better treat their patients. But you should always listen to your physician and not to somebody that gave a talk, because what they say may not apply to your child. Just a tiny little break here. This is from the Bahamas, a little bit more than a year ago, and I am right next to the person taking the picture. These are reef sharks. They're actually very friendly, and he's making the shark jump and do some tricks. They will do anything for food, just like a lot of different animals will. So they're all trying to make him happy so he'll feed them. So the mitochondrial cocktails, I've already mentioned that there's a couple other brands out there. There's what Bonnie Kaplan makes. There's the ARDC that's made by Jim Adams. This is the one that I make. This is a powdered form. Lemon, and this is a berry that you would mix with, you can mix it with water. It's best cold with ice. You can mix it with milk, with tea, with a smoothie. You can mix it with fruit juice, anything that you want. The only difference is the flavor, lemon and berry. This is energy needs. This is the same thing almost exactly, but it's in capsule form. I recommend this for children under 10 years of age that can't swallow. Over 10 years of age, you should be able to teach them to swallow, but obviously that's not 100%. It has everything in it that we have spoke about except for the omega-3s, and it doesn't have enough CoQ in it because those have to be separate. So every single thing from alpha-ketoglutarate, everything that we've discussed so far are all 8 of the major ones it has. And it hits the major pathways, cations, methylation, neuroinflammation, amino acids, mitochondria, obviously. It hits all the major pathways. Again, the CoQ, this is my brand of CoQ. It's private labeled from Konica. This is what they look like. You can just cut off the ends and squirt it out, or you can use a liquid form that you can find on the internet. I generally do in adults 200 twice a day. That should get you a good blood level in most of them. If you have a lot of GI disease, I really recommend 300 twice a day. In like a 6 or 7-year-old, I use 100 twice a day. It gives you some of the idea of the dosing. And then the omega-3. This is made for my own child, actually, who has a neurodevelopmental disorder, and he got much, much better. He had horrible ADHD. His ADHD got much better, and he got off the stimulant. I hate those medications. They cause mitochondrial dysfunction. They have a lot of side effects. Yes, I had my own child on it. Many of my patients are on it. Sometimes you need them, but they do have side effects, and nobody likes them. This is krill plus fish plus sunflower seed for the phosphatidylserine. So it makes all three of them together. And then the krill and the sunflower seed go directly across in the brain, high dose fish for the heart and the rest of the body. I've mentioned a few times about the excitatory to the inhibitory neurotransmitter ratio. These are the things that happen when you have too much excitation. I mean, pretty much the disease in your patients, certainly the disease in all of my patients. Families are always asking me, if my kid doesn't have enough energy because of the mitochondria, why does my kid seem to have too much energy? I mean, that's a good question. And when they asked me that 30 years ago, I had no idea. But now we know. It's the GABA interneurons. The GABA interneurons are very, very highly energy dependent, and they're inhibitory. If you have a toddler, a 3-year-old, and a cookie, and a mother, okay? Toddler says, I want a cookie. No. 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 I want a cookie. Okay. That cookie is gone. The mother has to sit there by the cookie jar all the time, or that cookie will be gone. The inhibitory neurons have to fire all of the time, or the excitatory neuron will fire. That's a weird thing about the brain I did not learn in medical school. The GABA interneurons, and there's a lot of them, they keep shooting GABA into synapses all the time to turn those synapses off. If they stop, even for a moment, the excitatory synapse will go off, even if it's not supposed to. So when your nerve cells run out of energy, what runs out first? The GABA interneurons that are on all the time. So in an energy deficiency, be it genetic or acquired, and remember, there's both of those in autism, your GABA interneurons turn off fast. And so you get hyperactivity, and this is what you get with hyperactivity. So you get autistic features. And if your excitatory nerves are going off in the brain at random, how can you think? How can you interact with people when nerves in the brain are firing when they're not supposed to, giving you weird thoughts and weird feelings? Does that sound like your patients? It certainly sounds like mine. That's really what's going on here. So yes, we need to affect the cations. The cations will help us to make the cells less excitable. Yes, we need to affect the mitochondria. We need to give more energy to those GABA interneurons. But we can help the GABA pathways as well. There are things that we can do to increase GABA. And here are some of them. You can give GABA. Yeah, a lot of it doesn't get to the brain, doesn't get from the stomach. But for whatever reason, when you give GABA to people, a lot of times they calm down a bit. So I put it in products. L-theanine, that's what makes tea soothing. It's not the caffeine, why people like to take tea over and over again. I guess it is the caffeine too. But the L-theanine makes you feel better. L-theanine causes more GABA. It increases GABA transmission. Magnesium, we've already spoken about that. That's very important for the mitochondria, but it's also important for GABA. It increases GABA, but it decreases the NMDA glutamate. That's the main excitatory one. So this increases the inhibitory and decreases the excitatory. And then B6, that was one of the ones we spoke about, that helps GABA and serotonin. Now, serotonin is excitatory and inhibitory. That's true, but it's more inhibitory. And serotonin is up here. 5-hydroxytryptophan, 5-HTP makes serotonin. So the 5-HTP helps the serotonin, and the B6 also helps serotonin. So when you're doing this, you're helping GABA, you're helping serotonin, and to a small degree, you're decreasing glutamate. What else can you do? There are drugs that you can do as well. Zinc. Zinc will decrease the glutamate. The excitatory as well. But there are drugs out there that can do that as well. Memantine is one. Amantadine is another. They can decrease their NMDA glutamate receptors, and many of the patients are on that. And so this is putting it all together again, a high-powered mitochondrial cocktail, whether it's from NeuroNeeds, which I own part of the company, so I have a conflict of interest, or it's from one of the competitors. The products are actually very similar now because if competitors are my friends, I know them. If they put something in there that I wanted in there, I put it in mine too. If I put something in, they put it in too. Our formulas are all better because of each other. I recommend a high-powered mitochondrial cocktail. Ubiquinol form of CoQ, because that will get across the blood-brain barrier. Fatty acid supplement, I recommend a combination, fish and krill together, maybe even with the sunflower seed. The zinc is great for decreasing NMDA glutamate receptors. Things to increase GABA and serotonin. Again, diet and supplementation. And again, the small print for the lawyers or whatever, I'm not recommending that anyone contradict their physician's advice. Discuss all treatments with your doctor. So we've gone over in the learning objectives why mitochondria and cations are important. Yes, it's based in the genetics, but it's also acquired in ways that we really don't understand, but they are important and they are treatable, and one goes to the other. But there are other pathways too. Inflammation is a major pathway. Other people will talk about that more than I will, but omega-3s are great anti-inflammatories, by the way. It's another way to do that. Neurotransmitters, we just spoke about that. Amino acids, well, amino acids are neurotransmitters and they're important in energy metabolism. And then methylation, that's your folate, your B12, and your magnesium, which are all parts of the mitochondrial cocktail as well. There's evidence for these 8, but that's just because people study that and they did a lot of studies. There's a lot of other parts I think are probably important as well. I really recommend a combination product. You'll get all of these and more. You get more efficacy and you have more tolerability because you're not only just boosting part of it. And there is a double-blind study. There's not a lot of studies on this. We had a double-blind study that we was doing and the university pulled out because the hospital decided it didn't want to do any more research anymore. And anyway, we had a double-blind study on our formulas that we have to restart. But again, combination products, less side effects, they work better. And so putting it all together, I know that there's a language issue here. And this is all very complicated, and a lot of this is probably very new. Again, just published 3 months ago, a lot of this. If you do both parents, because you need the parents to look to see what's de novo or new, not in the child, not in the parents. Whole genome, that's all over 99% of the DNA, the whole thing. That's not exome. That's not, it's doing all of the DNA, trio, WGS. And the autism physician looks at the back end of the computer and looks for new disorders. We can find an exact cause of your patient with autism 2/3 of the time. More than half, not every case. And you really need to have the, I recommend that your patients that are more severe, the ones that have more problems or refractory, they're just not getting better. Try the genetics, see if it gives you what you want. I suspect that it will. It won't in every single case. Obviously, nothing's that way in medicine. Nothing's that way in the world. You give me 3 cases, I don't help you in 2. Okay. Certainly I will in 1. And then it has to go for variantics, but we can help you with that. I have no conflict of interest. It's just the only lab in the world that has the bioinformatics now and the access to be able to do that. And I'm hoping that that will change. Thousands of genes that cause autism, but the number of pathways are small. That's why autism looks like it. You can see a patient, you say that's autism. If it's thousands of genes, how would it look like one disease? Because it affects the same pathways. That's why it looks like a disease that we can recognize. Energy metabolism and cations, critically important, somewhat genetic, somewhat acquired. Other pathways are important as well. Neurotransmitters, I've gone over all of these, very important. Treatment is predominantly dietary supplementation. I'm a physician. I was trained to use drugs. It just happens to be the diet and the supplements are what work. I still use drugs. Half my patients, like I showed you, I used a medication. I'm not against it at all. It's just the supplements are the most important, but drugs are important as well. Combination products exist. And I know a lot of your patients will not be able to do the genetic testing. I realize that. It is expensive. But the information that I gave you can help you, even for those patients that can't do the genetic testing. Think energy metabolism, think cation transport, think neurotransmitters, think neuroinflammation. Think about what products can help you on those pathways. The DNA is best, but you can do it without it. That's why I say do the DNA and the ones that are the most problematic, the ones that give you the most trouble. The other ones, you can try the products first, and if they're great and your patient works out okay, then you may not need the DNA, although it can still be helpful, as I showed you. And then here, this is my information. And again, if you're interested in the DNA testing, this is the email to Liz, my coordinator. If you're interested in the website to learn more about the DNA testing and how that can help you, this will go right there. You can take a picture of this. This is the article, the simple article on genetics. And this is NeuroNeeds if you're interested in the NeuroNeeds products. And also, you can just email me as well on these sites, so you can ask to get my email. And and they're straight here, actually. They're right up there. So I finished just about 10 minutes early again. I didn't know if you were going to have simultaneous translation or sequential, so. I'll just leave this up here so people can copy it down or take a photo or anything. And we'll let the organizers take over now.
Дякую, доктор Боус, за дві змістовні доповіді.
Thank you very much, Dr. Bowles, for those two presentations. A couple of questions from me, and maybe the participants will have their own questions too. Question number one, I need to say that unfortunately, the whole genome sequencing in Ukraine for children with suspicion of autism is not for free. So from your point of view, can you tell us, please, if we are talking that usually patients have to pay for their testing, is it worthwhile to use whole exome sequencing or whole exome sequencing, or are you looking on whole genome sequencing?
I cannot do what I do on whole exome sequencing. You can certainly get some advantage. You will find about maybe 20% will be positive if you do whole exome sequencing. What I do is looking at the raw data from the laboratory that does whole genome. So it has to be sent for variantics. It can be sent to variantics on a saliva sample or a sample that is taken from a swab of the mouth from anywhere in the world. So there's no reason why it can't be done from Ukraine. We've done it from all over the world. But it is expensive, you're right. And the price changes from time to time. It's about
Сьогоднішній день всякому випадку в нашій країні повногеномне секвенування десь відсотків на 70 дорожче, ніж
Whole genome sequencing 70% more expensive in our country rather than whole exome sequencing. So do you do whole exome and do you do whole genome? Because in your presentation you talk about whole genome sequencing, but do you have experience comparing whole exome and whole genome sequencing for diagnosis?
Yes, I do, and the whole exome is much, much less. The problem is the bioinformatics. It needs to be done by the laboratory variantics. At this point today, there's no other laboratory in the world that can do it, because they're the only laboratory that will give me access to the back end of the computer that will allow me to do that. If you do whole exome in Ukraine, I will not have access to that data. Even if they do give me access to the data, it won't be complete enough to look for de novos. So I can still find things, but instead of having a 70% chance I'll find something, it will be more of a 20% chance I'll find something. So it's that much of a difference. I realize that I'm going over some data that's not going to be highly practical for many of your patients, but I wanted to show it to show you that the treatment recommendations are based upon understanding the genetics in hundreds, thousands of patients. I have been involved in sequencing thousands of patients with autism, and these are the pathways. And even if you can't get genetic sequencing, if you address those pathways, the patient should get better most of the time.
Наступне запитання.
Okay, thank you. And the next question. In your presentation, you mentioned that the majority of children with ASD have de novo mutations, whether it's worthwhile in this case to do trio genome sequencing or trio genome sequencing because the patient pay themselves. So maybe we should do whole genome just to a small patient, not
You
trio.
can do just the patient, but again, you will find a lot less. If you do only the patient and you do exome, then you're probably going to get a diagnosis in about 15%. And that I showed you in the data is 14%, because those are the ones that the laboratory says, this mutation causes autism, we know it for certain. You will make a diagnosis in about 15%. Most of the mutations are de novo, they're not in the parents, and you have to sequence the parents. So if you do just the patient and you do exome, you'll make a diagnosis in 15%. If you do trio whole genome, we'll make a diagnosis in 68%, but there's another 15 to 20% that I'll be able to find polygenic causes, which I might be able to treat. So I'm actually finding about 85 to 90% I can give you information. So you're going from 15% to 75%. So, I mean, 5 years ago, I did the 15% because that's all that we did. That's all we could do. And I recommended that in all my patients because that was better than nothing. But I would recommend that for those patients that can't afford it, particularly if you have money put aside for only a few patients, and you would choose those patients that are having the most trouble, and that considered to do genome trios.
Коли ми з вами
Okay, thank you. When you mentioned energy needs, you mentioned that there are certain side effects that can be overcome. Can you talk more about that? Because we are talking about 40 component, highly efficient combined drug. From my point of view, I'm not looking at dietary supplements as something that I don't look at them as a medication, not medication. So maybe it will be interesting to hear about that for our doctors, So what kind of side effects do you see, and what kind of corrections you would recommend here?
I have never seen a serious side effect, meaning I have never seen anything that caused significant problems, nothing that really hurt the patient in any way, and I've never seen anything that was irreversible, meaning if in those side effects, if you stop it, they all go away, and none of them are ever severe. So that's the first thing. Mild side effects, yes, they can occur. By far, most likely is nausea. Any supplement you put into the stomach can cause nausea. When you put 40 ingredients in it, you can have some nausea. If you start at a low dose, like 1 capsule twice a day, and then you work your way up to the dose in the patient, or if you start at half a capsule and then you take it with a meal, nausea is rare. And if you get nausea, just go up slowly, more slowly. People that have a lot of nausea to medications, they know who they are. Start low, go slow. That's a good thing to say all the time. Start low, go slow. You're very unlikely to get nausea if you start low and you go slow. There are a few people that cannot take the full dose because of nausea. Sometimes half the dose is all they need. It's cheaper and it works great. So a lot of my patients take the full dose, and a lot of them take a half of a dose. I recommend always to try the full dose because it might work a lot more than half the dose. But you can see which one works best for you and your child. The other side effect that we see sometimes is they have too much energy and they're just full of energy. Because you give a kid who's sick more energy, they're going to get into more trouble. Sometimes that's just a child becoming more normal. And I tell the parents, well, that's the way normal children act. They get into trouble, they cause problems. So, I mean, that's what you want. But sometimes it does kind of hyperstimulate them a little bit. That is maybe 20%. There's 3 things you can do about that. Start low, go slow. Usually people that do that started at the full dose. If you give the body time to react, that usually doesn't happen. Second of all, again, not everyone needs a full dose. Some people, half a dose will work, or 3/4 of the dose. And then the third one, the calm needs that works on the neurotransmitters, that can usually work in the other direction. So if they're a little bit hyperexcitable, you can give them the calm needs to sort of balance them off. But usually the problem is if they have it, it's because you started it too quickly. The only other side effect I've seen is sometimes sleep. Some of them, if you take the medication, if you take the supplements right before sleep, it affects your ability to go to sleep. That's maybe 10%, not that common. So I tell them, take it at dinner, not at sleep time. Some of them I take it at 3 p.m., 1500. Take it when they first wake up and at 1500, not at sleep time. But that's rare and you can solve that. I haven't seen any other side effects. These are all vitamins and minerals. Everything that's in energy needs is in food. And I wouldn't expect there to be a severe side effect.
Дякую. Наступне питання, яке я
Okay, thank you very much. And the next question that I would like to ask you about two products. So indications to use in ADHD. We have some patients that we would like to try them, but you have high experience.
Yes.
Spectrum needs or energy needs?
Okay. If in a person with ADHD that is not severe, you can use focus needs. And focus needs by itself. Focus needs is a box that has 2 different ones in it. One is oil and one is powder. So it's one box that has 2 jars in it. So one product, really 2 different things. Focus needs alone, it's inexpensive. It costs a lot less than the others. And for ADHD, focus needs should work in most cases. For severe ADHD, I recommend the same as the autism.
І таке не зовсім просте питання.
Okay, thank you. And not quite a simple question. On one hand, omega has anti-inflammatory effect in active viral infection or herpes infection. We can get hyperexcitability when patients take omega-3 fatty acids. So usually we have those. So I'm interested, what do you think, whether it's worthwhile to use omega-3 fatty acids with active herpes viral infection or in any active neuroinflammation in a patient?
I have used it many times in PANS and PANDAS patients, and occasionally the mothers have said that it caused more problems, but it is reversible. The second you stop it, it goes away. But most of the time it's been helpful. But there have been some times in the like PANS and PANDAS that it can cause some side effects. But it's rare and it's reversible. So I think it's worth trying. About active herpes, I don't know the answer to that.
Тут я з вами повністю згоден, що це завжди є зворотні.
I fully agree with you that this is reversible. I thought maybe you could just share some life hack, what to use in case of neural inflammation for patients who use omega-3. We also see side effects, not very often, and this is quite often due to quite poor compliance of the parents of our patients, but the benefits are much higher, and I fully agree with you, and the process is reversible. Yeah, you're right.
But the medications sometimes have irreversible side effects. Again, I use them, but I prefer to use natural substances first. I've had several patients that have irreversible side effects from medications. I've never seen that in a natural substance yet.
Так, доктор Боулс, я вам дуже вдячний.
Thank you very much, Dr. Bowles.
You're welcome.
If you could stay for a while, now we will engage Dr. Fry. We have some interesting questions to him and other speakers.
Включіть, будь ласка, доктора Фрая. Добрий ранок, доктор Фрай.
Good morning, Dr. Fry. We've seen your presentation, and the audience has a few questions to you. If you could answer them, please. So the first question is, if there is any factor for complicated labor, can it be a trigger to project autism symptoms? What is your opinion on that?
I'm sorry, could you repeat the question?
Чи є фактор ускладнення пологів, тобто довготривалі пологи?
The complication of labor, of delivery, let's say long-term delivery, etc., can it be a trigger for manifestation of autism symptoms or ASD symptoms?
Yeah, I'm very glad that you described it that way, as a trigger and not a cause of autism symptoms. There are many complications associated with with delivery and birth that have had epidemiological associations, with autism. So, it's very possible that a brain or a physiological system, that's vulnerable, something additional could trigger it. And it's true that, maybe some type of something that happens in delivery could. The other problem, though, with trying to sort this out is that we don't know many times if something that is predisposed in the fetus, actually causes those issues with delivery. For example, if the physiological systems in the fetus are not completely mature or are not working normally, the trigger for delivery may not be as robust as it would be in a child without those types of disorders. So it's a complicated area to really piece out what's the chicken and the egg, so to speak. But sure, any type of physiological stress could cause a trigger to have any neurodevelopmental disabilities if there's an underlying deficit already, such as a mitochondrial issue, some other metabolic issue, oxidative stress, or inflammation.
Таня, скажіть, будь ласка,
Thank you. Another question is, what drugs or supplements or methodologies do you use in patients with neural inflammation and systemic inflammation?
So it's a good question. So I know I really look at neuroinflammation and the dysregulation of the immune system as part of a more of a systemic problem. That is that we like to call it the terrible trio. We have immune dysregulation, oxidative stress, and mitochondrial dysfunction. So we kind of have this vicious cycle that we have to stop many times. So I always start with looking at things that are easily treated, and those are usually the metabolic issues, that is the mitochondria and oxidative stress, which may be the causing or worsening the inflammation and some of their downstream effects. So so that's where I usually start. And then, if there's inflammation, so to speak, then there's many different treatments where you can start for supplements, anywhere from, of course, omega-3 fatty acids, turmeric, and such, to more serious medications. Another place, of course, that's very important to look at when you see inflammation in the body is the gut. So so dysbiosis and dysregulation of the microbiome many times can cause inflammation, and we've seen many improvements in the immune system function by rebalancing the gut. So it's really, and I think like everything with autism and many diseases, it's just not one piece of the disorder. The inflammation is just one piece of the disorder, and you may have to treat things around it to decrease the inflammation.
цікаве питання мікробіому. Скажіть, будь ласка, які методики для
That's interesting about microbiome. And what methodologies for microbiome, what methodologies do you use? Genetics or maybe some other methods in your clinical practice?
I use I like to say I use all of the above, because it is a very complex disorder. So we have to leave no stone unturned, so to speak. I start out by looking at metabolism, GI symptoms, any type of neurological issues like underlying seizure disorders or seizures during sleep, and genetics. So I've learned from Dr. Bowles to use the Variantex and be able to go down into the genome and look for some of these variants that may be causative or worsening things. Of course, If it gets complex, I refer to Dr. Bowles, to interpret it.
Я хотів би переуточнити, ви також в своїй практиці використовуєте...
And in your practice, do you also use genome sequencing, not exome, right?
Yes, I do whole genome sequencing. I do the Variantex whole genome sequencing because not only are you able to get all aspects of the genome, that is sequencing of all the genes, trinucleotide repeats, copy number variations in mitochondrial DNA, but then they have a tool that allows you to actually go down and look at every variant in the genome, so you can decide for yourself whether it's something that is maybe significant or not significant. And sometimes, many times, we find something that's very interesting that relates to the disorder. And I think it just kind of supports the fact that you can't see anything in isolation. That is, you can't just do genetic sequencing and tell everything about the patient. You need the information about the patient so that you can interpret the genes.
Прозвучало дуже цікаве запитання. Скажіть, будь ласка...
There's another interesting question. What is your attitude to the diet for treatment of epilepsy in children with ADS? And if there is such a diet, do you use it in your practice?
Yeah, I mean, there's many different diets. I definitely, inflammation is something that is involved in epilepsy, if not causing the epilepsy, can worsen the epilepsy. So anything that decreases inflammation would be a good idea, and that depends on the child, whether they may have reactions to food. Some do, some don't. But the ketogenic diet is really something that we found is very helpful in seizures with autism. So we know it's a very helpful treatment in seizure disorders and refractory epilepsy. For many mitochondrial diseases, it seems to be very helpful. There's also data that suggests that it improves symptoms of autism in individuals with autism. And in our seizure survey that I did with Jim Adams a while ago, we found that the ketogenic diet was the highest rated treatment that reduced seizures of any treatment, both drugs and non-drug treatments.
Ще одне цікаве запитання.
There is one more interesting question. Actually, I will combine two questions. In case of cerebral folate deficiency, we, as a rule, observe high level of B12 and B9 in blood. So we can see excess of these vitamins. And the question is how to decrease the excess folic acid in blood. What is your perspective? Do we need to decrease it? And if yes, then with what methods?
Folic acid, you don't want in blood, but folate you do. You really, the finding of high levels of B12 in the blood is actually a sign that it's not getting into the cells. So, many times we see with B12 that the children have an insufficiency, and we measure this not with B12 levels, but with metabolites like homocysteine. And what's probably happening, because we know there are polymorphisms on the B12 carrier that can affect B12, getting into the cells, and we know from the evidence of Richard Deeth that B12 is low in the brain. Our presumption is that the levels of B12 are high in the blood because they're not where they're supposed to be in the cells. And that's a sign that you actually have to give higher levels of B12 to essentially push it into the cells. Of course, you can measure other metabolites to see if the child needs it or not. For levels of B9, when we treat, cerebral folate deficiency, that's exactly what we're doing, is trying to get high levels of folate in the blood so that it will essentially be pushed into the brain through the reduced folate carrier. So we actually want those high levels. Of course, not folic acid, but folate, folic acid being the oxidized form of folate, which is not processed by many people well. So we want reduced folates at high levels to get into the brain. And of course, these are all B vitamins, so you pee it out. So we say the worst thing you could do is make expensive urine, from these treatments. So they're not harmful. They can, sometimes high B12, high B9 can cause a little excitability, but then you just decrease the dose or stop it, and there's no harm done.
Якщо ми візьмемо знову ж таки дози
If
фолінової,
we speak about the doses of leucovorin, the brand which is currently used in the United States, the treatment doses are 0.22 milligrams per kilo of weight. Can you tell us, do you select the dosage using empirical method, or do you use maybe some special methodologies to prescribe a certain level for a certain dose for the child?
Really both. There's many reasons for folate not to get into the nervous system. One of them is the folate receptor antibody, which blocks the folate receptor from bringing folate into the brain. And those antibodies can be at different levels. And we're also finding something called the soluble folate receptor, which seems to have a more severe effect on getting folate into the brain. And then the other reason is because there's any type of metabolic or mitochondrial disorders. So individuals with mitochondrial disorders, actually the literature suggests anywhere from 4 to 8 milligrams per kilogram. We really have to put all the information together. We usually start out at the standard 2 milligrams per kilogram, or 25 milligrams twice a day. And then depending on the weight and the situation and the response, we many times will increase it. There's also some literature that suggests giving leucovorin 3 times a day may be helpful pharmacologically. So that's sometimes what we try in certain patients.
коли обговорювали церебральну фолатну недостатність,
When we were discussing cerebral folate deficiency today, we were saying that in this situation, we mostly rely on physician's intuition. As far as I understand, that you practice the same. So you give the dose and then you look for the most effective dose, which will not lead to overexcitement, but which will have therapeutic efficacy.
In general, you guide that with the biomarkers of, what you think the range should be about. But yes, I think it's all a very empirical process, because as much as we'd like to think that by looking at the genes, the biomarkers, we have all the information, people are complex, and we really have to use our intuition to treat the patient, and that's the art of medicine.
Якщо ми знову ж таки повернемося до фолатного обміну,
Going back to folate exchange, vitamin D is one of the stimulators of RFC gene, which regulates the penetration of folic acid. In your practice, do you use a high dose of vitamin D, 4, 5 units, or you start with the low dose, 2000 units? So we're very interested in how to use vitamin D, because we have different opinions. In your presentation, you mentioned vitamin D, and if you could just expand a little bit more on that.
Sure. I go by levels of vitamin D. You have to watch vitamin D levels because vitamin D is tricky, okay, because it's a fat-soluble vitamin. So it's stored in the fat tissue. So when you have vitamin D levels, not only do you not have reduced intake, but you've actually depleted all your stores of vitamin D. So the first thing you have to do is first replenish those stores. So you may need to give high doses at first to replenish those stores. But once the stores are replenished, then the level can go up very fast. So then you have to decrease the dose as far as maintenance and watch the levels. I like to keep it around 50, as a good level, so it's not low, but it's not extremely high in my patients.
Наступне питання.
And the next question, we discussed that with Dr. Bowles. In Vivere Clinic, we believe first that we fight the inflammation, we get rid of the inflammation, and only after that, we start using drugs or cocktails to correct mitochondrial deficiency or insufficiency. So can you tell us, when you correct the mitochondrial dysfunctions, the secondary one especially, so do it one by one, or at the same time you try using mitochondrial drugs already on the first phase as a first step? Thank you.
I start with the mitochondria because it is the one that's easiest to treat. I mean, that doesn't mean that I wait to try inflammation. I will usually give advice that has multiple things in it and do one after another. And again, start low, go slow, but I'll usually start off with mitochondrial treatment.
Ви в даному випадку використовуєте...
And in this case, do you use the cocktails, mitochondrial cocktails, or do you combine mono supplements, coenzyme, acetyl-carnitine, or other groups, or do you start with the most spectrum needs that we know perfectly well?
I start with spectrum needs if the child cannot swallow, and energy needs if the child can swallow. Plus the coenzyme Q10 in the ubiquinol form, plus the krill and fish oil, omega-3. So I start with those, and then I usually then get the DNA at the same time, and then based on the DNA, that I'll treat other things. But I'm also treating the symptoms. So if there's like migraine, I will use more riboflavin, or if there's constipation, I will use more citrate or magnesium. So I'm also thinking of what the symptoms are as well. But I start with the combination products.
І в мене останнє.
Okay, and I have my last question for today, dear friends. So we usually we do the assessment like before, pre-treatment and post-treatment every 3 months. In your practice, how often do you check the treatment efficacy? Because very often in studies, when we look at the studies, we see that you do that, but how frequently, how often do you do the assessments? Again, we are not talking about money, but just how often is optimal?
I usually don't do very many assessments afterwards. I obviously will ask a lot of questions and to see what's better and what's worse, but I often do not get numerical levels afterwards. I don't know if Dr. Fry, what you do.
So I do, I follow patients with a standardized metric every time I see them. So every time they come to clinic, I use usually standardized parent-reported symptoms. I use the aberrant behavior checklist and the social responsiveness scale, so I can follow symptoms over time. We've used other instruments in the past, but I'm a big believer in each time you see them, you want to get some type of objective metric to see which way they're going, and it's very helpful when talking to the parents and talking about the child's symptoms and putting the child in context. You know, because sometimes the parents may say, oh, you know, he's extremely hyperactive, and then you can, you know, show them that actually the score, you know, compared to other kids, you know, is quite low, you know, and that we should concentrate on other things. So, you know, there's for me, I use standard metrics every time I see a patient, so I can see what their progress is in some type of objective manner.
Я отримав відповіді на всі запитання,
I
що
have received your answers to all the questions that I wanted to ask, dear colleagues and the other speakers. So you're all with us online. Can you tell us whether you have any specific questions? So,
Well, I mean, I was
colleagues.
just, that's for us or for other people? Sorry.
That's for other Ukrainian speakers, so whether they have questions.
до іншого українського доповідача ми, власне, чекаємо, коли він вийде.
Yes, it was a question to the other speaker, because I know he had some questions, but he is not with us, not online at this point of time. So we're just waiting whether he will appear or not.
Доброго ранку.
Макар Васильович, які у вас є запитання до наших американських
So
колег?
dear Makar, do you have any questions to our American colleagues? I have one question. Please turn your mic on. My mic is on. So it's on. Can you hear me? Yes, 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 we can hear you. If we had an opportunity, of course, we would do the trio genome sequencing to all newborns, like everyone, but so far it's not possible. So, but my question is, do you use in your practice microarray test in order to see duplications or deletion syndromes, and how often deletion or microduplication matter in autistic spectrum disorders? So probably that's a question to Dr. Fry and Dr. Bowles too, I think, with regards to using microarray in your practice.
I haven't used it in the last 15 years because I use
Якщо можна, щоб ми знали, хто
Yeah. The whole genome sequencing gives you microarray information, but I used microarray for about 15 years. I used only microarray because that's all that we had, And so I know what kind of information you can get from it. You get information in autism about 10% of the time. Maybe around there, but 7, 8, 10%.
Дякую. Дякую за...
Thank you for your answer. And in current guidelines on autism, it's recommended to start with microarray. So it looks like, from your point of view, those guidelines are obsolete already, right?
Things are moving so quickly that guidelines are obsolete when they're published practically. It's an interesting part of the times that we live in. I do believe that the American guidelines changed it finally about a year ago, but until about a year ago, they were recommending microarray, and now they're recommending whole genome instead.
Дякуємо.
Thank you. Dr. Fry, what is your point of view with regards to microarray test?
Yeah, I'm the same with Dr. Bowles, and I've been, following it, since the beginning when we just had microarray, and we did that, standard on every patient, and then we started having, panels and then whole exome, and now we have whole genome. And so whole genome gives us everything at once. So I don't see the point in kind of delaying this whole process of going up the ladder when we can just do one test and get all the answers. Although I must say that it's a very complicated test, so you need to have the resources to interpret it correctly.
With the idea that price is a major concern, I know it is everywhere in the world. Whole genome is cheaper because you get exome, mitochondrial DNA, microarray, pharmacogenomics, and Fragile X all in one test. It costs less money to do whole genome.
Если бы они еще стоили $1, то было бы...
Well, yes, if it was just only $1 to pay for that, that would be wonderful. Yeah. Okay, can you hear me?
Да, если бы они стоили вообще $1...
Yes, so just to repeat, if their cost was just $1, would be wonderful, but it's not. Yes.
I understand.
Yes. И очень часто на приеме...
And also very often patients might ask, okay, so we have found some genetic disorder, but gene disorders are not treatable, and it's very difficult to convince people that genetic disorders can still be controlled and treatable in some cases. So how do you manage situations like that? How do you explain that to patients?
We have the same problem here. There's a lot of providers in the United States that do not believe that genetic disorders can be treated. And they want a double-blind study for every single thing they give instead of, you can see we use evidence-based medicine, but we try to treat the patient as best we can. And we will say, well, there's some data that's suggested, let's try it, even if there's no double-blind study to prove it. But we have the same problem in the United States that a lot of physicians, many of them well-known, do not believe in treatment, or they don't believe that's their role to treat. So we have the same issue. That's why I like to speak directly to the families and directly to the doctors that are speaking to the families, and to teach them that we can do things, and to show them the proof.
Проблеми.
Я дуже радий, що ми з вами йдемо.
I'm really happy that we go in parallel, and Makar has started to smile. Because regardless of the fact that we do not have the protocols for the majority of genetic mutations, still we try to do at least something. At least there is something described, something published, something that we can have an influence on. Yes, so that we do the same. And another question. My microphone is on. It's on. So, another question for the future. We plan to work with epigenetics, and there is already some pre-work, preliminary work that we have done. So, what do you think, dear professors, both of you? Is it worthwhile to work in that direction, in the direction of epigenetics? And what kind of diagnostic methods would you use, or do you use if you do that at current time? Thank you.
Well, I find mutations in genes that are involved in regulating the genome all the time. That was one of the 7 categories that I showed you, the gene expression. That's all. Those are all the genes involved in epigenetics. I try to figure out what genes are turned on and off, and what I can do to turn them on or turn them off if they're in the wrong position. So that's what I'm often doing, looking at the literature. Also, many of the treatments that we're talking about are epigenetic, folate, B12, magnesium. So we kind of have been talking about that the whole time. Also, we're always talking about genetics and environment influences the genes by epigenetics. So why we didn't use that word, everything that we've said has really been considering epigenetics.
Да, и мы, например, еще используем там, и куркумин тут же самый тоже влияет
We
на это.
also use turmeric, and Zoya Rosocha, one of the speakers that we work together with, so has some experience on those epigenetic variants, treatment and testing of our patients with regards to epigenetic testing. So now, actually, there might be some problems with internet because the air raid alert has just started in Ukraine a minute ago. Volodymyr, so everything is okay. I'm online, connection is on, but have you heard that there is the air raid alert? Yes, yes, yes. We have heard that. We got the message about the air raid alert.
I hope you're underground.
So what's the question? I just wanted to add a little bit. It's not just B12. Not folic acid, B12, and magnesia influence the epigenetics, but also turmeric, and we use a special form of turmeric and have good results with that. Turmeric, I'm sorry.
I use turmeric too.
Ну, turmeric, yes. У меня нет вопросов, Владимир Михайлович.
Скажіть, будь
And
ласка,
I'm done with my questions. Can you tell us, dear other speakers, maybe you have some more questions to our American colleagues, because if you don't mind, if you don't have questions, we would like to wrap up. Dear Zoya, do you have a question? I have no questions. I understand everything. Everything is clear. Thank you.
Thank you very much for having us here.
дуже добре, що ви появилися. Скажіть, будь ласка.
It's great that all other speakers are with us and on. So a couple of months ago during the conference, we discussed genome sequencing and testing. Do you think, what's your opinion? So microarray can be used, or the genome sequencing is enough? Your opinion? So that's a question to whom? To you. Okay. If we cannot do the whole genome sequencing, then you can do microarray, but it's better to do whole genome. And if whole genome is done, then microarray is not necessary. If it's exome sequencing, then microarray or CGH array is okay to be done on top of exome. so we can get a consensus. So when we have to do the genetic or gene sequencing, then we start with whole genome sequencing. If we don't find anything there, then we have to think what other options we can use to look for genes, affected genes. So for today, we have heard all points of views that whole genome sequencing is the most complete method of diagnostic search in problems with patients who have suspicion of ASD. And if I may, I would like to add a little bit. For example, right now I have a child, a patient, SCN8A gene mutation, and genome sequencing actually identified, detected the problem. So the mutation was not in the exon, but in intron. And that led to splicing. And that led to the defect in the gene defect. So as of today, true, the genome sequencing is the best advanced method that will show you more, but it requires more knowledge and more resource.
It requires significant resources to interpret it no matter what you do. But yes, if you do exome plus microarray plus mitochondrial DNA plus Fragile X, yes, it still requires a lot of resources to evaluate that and really look at everything. Whole genome will do everything, but it still requires a lot of resources to interpret.
I agree, absolutely.
Добре, я дуже вдячний вам.
Great. Thank you very much, Dr. Fry, Dr. Bowles. Have a great and fruitful rest of Friday. It's getting dark here already. And if you don't mind, we will proceed with the accomplishment of our conference. Thank you very much once again for your very meaningful presentations. And it's really good that we are moving in the same direction and using the same methodologies. I think that similar conferences, we would try to hold similar conferences as much as we can. Thank you very much and have a nice day. Thank you, Dr. Bowles. Thank you, Dr. Fry.
Goodbye.
Побачення.
Goodbye.
Якщо можна, тоді від'єднуємо Zoom, і в мене кілька оголошень, і я би хотів, щоб ми перейшли до завершення конференції. Об'явили повітряну тривогу. Ми і так весь день прекрасно, продуктивно відпрацювали. Дякуємо нашій протиповітряній обороні, дякуємо нашим Збройним силам, що цей п'ятничний день пройшов спокійно. Зараз кілька оголошень. І так як ми обіцяли, зараз ми проведемо розіграш серед тих учасників конференції, хто зареєструвався. Ми зараз уявімо, що буде барабанний дріб, і ми рандомно проведемо розіграш участі в одному з наступних мастер-класів, який хочемо вибрати. Давайте. Так, виграв Галябар Василь Савович. Організатори вийдуть з вами на зв'язок. Дякуємо за участь. Ви в нас переможець. Так, по питаннях з нашої точки зору. нашої точки зору найбільш цікаве питання є. Зараз я дивлюся голосування. На що може вплинути атрофія правого гіпокампа у підлітка зраз? Прохання звернутися до організаторів по номеру телефону 067 327 94 14, хто задав це питання, і ви отримаєте також безкоштовну участь у будь-якому з наших наступних майстер-класів. Буквально через 5-7 хвилин я закінчу конференцію, ще лишилося кілька організаційних питань, і ті, хто хоче отримати бали, зокрема за конференцію є можливість отримати 15 балів БПР, можуть приступити до тестування. Згідно нових правил, ви маєте надати відповіді сьогодні до 23-ї години. Я подякував нашим Збройним силам, але ми маємо розуміти, що без допомоги нам би не вдалося провести дану конференцію. Тому, перш за все, я хотів би подякувати всьому колективу клініки Вівери за участь в конференції, за допомогу в організації і, зокрема, особливо доповідачам Макару Шийко і Наталі Пінковській. Далі я б хотів виразити вдячність нашому генеральному спонсору компанії IGP Farm, яка, ви бачите, представлена інтернет-платформою IGP Kia. Це є єдиний офіційний представник компанії нейророзвитку, яку ми сьогодні обговорювали в Україні. На жаль, в Україні БАДи не проходять на сьогоднішній день реєстрацію, як це у всій Європі. І ми зіштовхуємося іноді з тим, що абсолютно різні варіанти попадання саплементів в Україну. Завжди будьте обережні, рекомендуємо тільки офіційних поставщиків, офіційних представників, офіційні представництва, тому що це все є для наших дітей, і тут, власне, та ситуація, що треба бути переконаним, що і де ти береш. Далі я би хотів виразити вдячність нашому другому головному спонсору компанії Синево за те, як вона оперативно, добре, прекрасно робить аналізи. Дякуємо за підтримку. Українському, європейському виробнику ліків компанії Асіно, а також всім, хто допомагав в організації